Welcome everyone, my name is Craig Fitch from Oculus. Thank you very much for attending tonight's webinar on tear dysfunction and OSD strategies for successful management. If you have any questions this evening throughout the webinar, on the right-hand side of your screen, you have the opportunity to ask those questions, and towards the end of the webinar, we'll have Dr. Epstein answer those questions for you if we have enough time. Dr. Epstein is going to be talking with us tonight. Dr. Arthur B. Epstein is a co-founder of Phoenix Eye Center and the Dry Eye Center of Arizona. He heads the practice's Dry Eye Ocular Surface Disease Center and services as its director of clinical research. Dr. Epstein is a highly regarded educator and popular speaker. He has presented in excess of 1,000 invited lectures throughout the world. He is also a prolific author who has published hundreds of articles, scientific papers, and book chapters. A contributing editor for Review of Optometry and executive editor of the Review of Corneal and Contact Lenses he founded, and serves as the chief medical editor for Optometric Physician, the first e-journal in optometry. Ladies and gentlemen, welcome Dr. Art Epstein.
Thank you, Barry. And good evening, everybody. And thanks for taking time out of your busy days or busy evenings, family time, dinner, and other things, because I guess it's probably still more in those places. To join me, and appreciate the kind introduction. Actually, let me just silence my phone here. Invariably present the office whenever you're doing something important. Anyway, this is one of my favorite lectures, maybe my favorite lecture of all time, and it really captures a lot of what I've learned over the past few years. The area of ocular surface disease and what we call dry eye has literally exploded. And what's great about this is a very, very important area for optometry. I think it is an area that is literally owned by optometry. Let's do a little housekeeping out of the way first. Okay. Okay, that's why. There we go. As with any presentation, obviously there's the regulatory environment required disclosures. Those of you who know me know that I pretty much say exactly what I think. I do acknowledge Oculus response screen that they definitely appreciate it, and most of the companies you see here either sponsored lectures or research, or sometimes have been nice enough to actually listen to some of my opinions, which isn't always the easiest thing to do. So this is really where I start with patients, because most patients that I see in my practice, which is not completely, but getting more and more almost exclusively limited to dry eye and ocular surface disease, really have a tremendous amount of misinformation that they've heard and have had experiences with events that have failed and the invalidation of how they feel and what their own clinical experiences are. So I typically start with what do we have tears? From the patients, it makes a lot of sense. As you probably have observed, a lot of patients come in and they complain that it's run down their cheeks, and they don't understand why they could be diagnosed with dry eye and have this excess of tears. So, I begin to explain that the reason why we have tears is actually, relatively, straightforward. It's simply because the eye itself is not smooth or regular enough to actually produce a sharp enough optical image. In fact, sometimes, it's a caveman sitting on a ridge looking out into the distance. One sees something, takes off and runs, and the other one stays just trying to figure out what it is and eventually gets eaten. The one who survives obviously is the one who produces, so there's a very, very strong selection pressure for having sharp, clear vision, and frankly, the surface of the eye isn't capable of doing that by itself. Believe me, the last thing an engineer who was building an ocular surface would do would make it wet, because that entails a whole host of adaptations. Keeping it, wet, keeping it stable, producing tears, draining the tears, preventing infection, nutrition issues. I mean, it's really very, very difficult to do that. So having tears with an effective strategy that didn't really have other solutions. It's the reason why, we actually, act here. So, typically try to create this mental image of this, clear crystal lake so they can understand that. I think developed this way over the past couple of years. I'm probably familiar with seeing the various definitions from TFBUT and so on. This is the working definition that they use dry eye multifactorial disease. Here's not the two are really completely and actively linked together, and that's something that Morgan Shepperstein, who's one of the great theorists in the area of dry eye and ocular surface disease. We have what patients call dry eye. It represents the failure of one of the functional units. We'll talk about that in just a second. Really there to protect the ocular surface, create a stable tear film, sharp, stable vision. And despite all of the challenges we face, we have patients that live in Arizona where it's really dry, in Colorado where it's really high. I mean that in altitude sense, as well as travel all over the place. So human beings have extended throughout the challenging environment of the world and still manage to survive. The vast majority of dry eye, frankly, is due to lipid deficiency, and we'll be talking about Meibomian dysfunction rather extensively today.
So we were talking about, what we learned in school. We were talking about our, traditional series of tri-layer tear film, and that goes back to the 1950s. And we've used it, and we rely on it even to this day. I think we will recognize that that's really not an accurate way of looking at the tear film, that all of these elements, the mucin layer, the aqueous component, the lipid layer, really all intermix. And in fact, it's in that intermixing that really makes for this, brilliant conception of how a tear film works, and really gives us some perspective on how we can address some of the issues associated with the tear film. So at its base, the tear film really has a major challenge. How do you stick to a cornea that is made up of epithelial cells that have a phospholipid bilayer? We all learned that in histology. The surface of the eye is actually inherently hydrophobic. And obviously water doesn't stick to things that are hydrophobic. So we understand that the Glycocalyx is a transformational layer. What it does is it takes the hydrophobic surface of the cornea and it changes it, transforms it, if you will, into something that's hydrophilic. The microvilli give increased surface area, and that serves pretty much as the foundation of the tear film. It allows it to stay in place despite the forces of gravity, which even on a plane surface, just a flat surface, would pull it down. We also recognize that the lipids produced by the Meibomian lens are actually very complex, and this is very important. And it's important to understand these things because it really goes to how we treat these patients. How do we effectively fix problems that patients are having without understanding exactly how the normal tear film, the tear structure actually works. So the lipid layer consists of two discrete components, actually each one made up of a number of highly specialized elements. And in general, one is a nonpolar lipid layer, which is nonpolar in the sense like Wesson oil or Castrol if you're into fixing cars. And there's a polar or a phospholipid layer that actually serves as the glue that holds the oil to water, because frankly, oil and water just don't mix. So how is it that this oil layer stays cohesively and coherently over the surface of the tears? It does because of phospholipids. That will be important when we discuss some of the tear formulations. I think the most important thing, and when I spend time explaining to patients, is that the tear structure is very complex, but it's easily understood if you think of a house. A house has a foundation, and indeed the tears have a foundation, the Glycocalyx that I just described, and it allows the tears to stay in place the same way you wouldn't build a house on sand, because the shifting sand would destabilize the house. The house has walls, the tear film has walls, except the tears have walls that are viscoelastic in nature, so they're able to absorb force and rebound within milliseconds to create that stability that's so essential for vision. And just like a house, the tear film has a roof, except in this case, the roof is made up of lipid and phospholipid, which serves almost as the nails that tack the shingles down to the surface of the roof. if you have a hole in the roof, water gets in, it eventually destroys the structure of the walls and eventually erodes the foundation. Likewise, if you have a hole in the roof, if you have insufficient lipid or you have non-functional lipid, what ends up happening is moisture goes through the tear film because of the lack of evaporative barrier, and eventually the tear film collapses and then ends up producing surface damage, changes the architecture, and creates irritation and discomfort, and that's the reason why the patients typically come to see us. And I think when patients see this, they really, really get it. So I'm going to share with you exactly what I do, pretty much every day when I see patients, what I consider to be, at this point, and I literally learn something every week, a distillation of what I think is the most effective dry eye workup, and then we'll get into therapy. So number one, you have to quantify patient symptoms. Why do we have to quantify it? Because if you ask patients a social question, you're going to get a social answer. Hey, how you doing? Or in Texas, how you all doing? Or in New York, how you doing? How you doing? Patients, I'm doing good. I'm doing good. Patients always want to please us. We don't need to be pleased. We really need to understand the patient's experience, and the best way to do that is with a device, a tool that will give us a quantified answer. And the two things that I use, and I tend to use the OSDI more than I use the speed test, although the speed test is perhaps a little shorter. These two tests are available for free on the internet. OSDI was originally produced by Howard Dan when they introduced Restasis. Speed is a Donald Korb invention, if you will, that allows for very rapid quantification of the patient's experience. And once I have this, number one, I have a sense of where the patient's at, what their experience is, and more importantly, I have a fixed number, a fixed assessment of the patient's experience. So I can go back and see where they are after I've initiated treatment, which is very, very important. Tear osmolarity can be very useful as a screening tool. Some people use it, some people don't. There's some controversies surrounding it. There are people who absolutely love it. There are people who absolutely hate it. And I'm not going to get into any of that right now, but like an assessment of the patient's experience, osmolarity is believed by many people to be an effective screening tool. Certainly all of you recognize the tear film breakup time, and essentially tear film breakup time is more complex than we typically think because we really don't think a lot about it. So we put fluorescein in the eye. Basically, we have the patient blink and we start counting 1 Mississippi, 2 Mississippi, and we measure how rapidly the tear film breaks up. And I will tell you that when we see breakup that occurs spontaneously in different areas, and if we repeat this, you should repeat it more than once and just see where breakup is occurring. When we see that, what we're actually seeing is a lipid deficiency. What I mean by that is if you have an area of breakup that occurs over and over and over again in exactly the same space, it tells you that what you're seeing is damage to the underlying architecture of the tear film. So, I'm sorry, of the ocular surface. So the tear film cannot stick because the architecture has lost its essential hydrophilic transformation and now is hydrophobic, so it won't wet and it continues to break up constantly over the same place. When you see sporadic breakup in different areas, what you're really seeing is a lack of cohesivity of the lipid layer. And we see this, we measure it, you're all familiar with it, and it's very, very important to recognize that those differences can be important from a diagnostic point of view. So not only should you do breakup time, but you should have the patient repeat it at least 2 times, if not 3 times, to see exactly where the breakup is occurring. There actually are better ways for measuring it. Again, this is an Oculus sponsored presentation, and again, I appreciate their sponsorship of this. This is one of the best instruments I've ever invested in, and for those of you who are looking to buy a topographer, which is something I think is an essential instrument for all of us, this is really, to me, an obvious choice, not because of its topography capability, which is fine, more than adequate, but because it really provides a dry eye test suite, including non-invasive breakup time, and I'll show you some of that, Meibography, which is simply amazing and probably the single most important tool I have for getting into a dialogue with patients. Tear meniscus height, tear film scan, it's capable of measuring tear viscosity indirectly, and you can even assess the lipid layer in a non-quantifiable way. So it's very, very helpful. So this is an example of the Keratograph 5M non-invasive Keratograph breakup time test. And you can see that most of the corneal is green, and you see that little area of orange The orange corresponds to an area of more rapid breakup time, probably around 9 seconds or so. And I describe this to a patient as really a measure of tear stability, because what you're seeing is how long the tear film remains intact. And it varies in severity and corresponds very, very well in my experience with the patient's experience. And I've literally had patients break into tears when I explain that they're not crazy and that this really corroborates exactly what they're describing. Because so often these patients feel really unheard, and I think that's a very, very important element. There's a very large psychological component to this, because dry eye isn't something that comes in with an obvious defect. Dry eye is something that you suffer with silently and alone, and it's very, very hard for the patients to get their colleagues, their family to understand exactly what their experience is. But certainly staining is one of the more important metrics that we use. This has been a classic conjunctival staining in a dry eye patient. It can be very, very severe. Here's a patient where the entire surface is involved, and obviously this is a patient in serious trouble. You can see this patient has really severe meibomian lens dysfunction, horrible blepharitis, and this is the kind of eye that can be lost if this patient isn't managed properly. So fluorescein staining is a very useful tool, as is lissamine green. Lissamine green stains devitalized cells or areas that are keratinized that are no longer functioning normally, and we use these two stains all the time, as part of the normal test suite, and then discuss it with the patient afterwards, as I'll explain. One of the things we often don't do, and we should do, and I think is very important, is assess lid closure. And many of these patients, and what I mean by many, a not insignificant number, probably 20 to 30%, have exposure issues due to a lack of proper lid closure during sleep. And I always look for corresponding staining, and I always measure Bell's phenomenon. And this is a classic example of exposure staining. This is where the lid just doesn't seal properly, and this patient doesn't have an adequate Bell's. And that's one of the things that ophthalmic plastic surgeons usually are aware of. Sometimes plastic surgeons are not. And if you have a dry eye patient who has had lid surgery and they have not had their Bell's assessed, and they have their cornea exposed like this, these patients will have whatever dry eye issues exacerbated significantly, and in some cases really will throw them over the very, very edge. And I've seen this in patients with Sjogren's. I've seen this in patients that have had no dry eye previously and suddenly have very, very severe symptoms. And I've seen it with patients who have had symptoms and then realized that they would be in jeopardy of worsening their symptoms. Another test that's critically important that we often overlook is very simply pressing on the lid to see if we express any oil. Diagnostic expression is very, very critical because it allows us to see whether or not Meibomian glands are functioning. It's a very simple, easy way to do it. Essentially what you're trying to do is apply sufficient force to emulate the force that occurs during a normal blink. We'll talk more about that in just a minute. Physical observation of the Meibomian lens is relatively straightforward. We can see inspissated glands here. You're not supposed to really see glands. You really have to look for them, scan for them. These glands are all plugged. We have one of my favorite patients. In fact, as soon as I see the picture, I break into a smile because he's a funny guy. And as you can see, he had a transplant, but he also had the good fortune of having translucent lids, so we can actually see the congealed toothpaste-like meibome still in literally just coming out of the Meibomian gland orifices with minimal pressure. And meibome varies, as we'll discuss, from clear liquid to very, very thick and waxy, in fact, almost hard. And here we have a patient who has very, very classic Meibomian gland dysfunction. You can see the plugs, the lymphatic vessels, and you can see the contact lens that is on this patient's eye with almost no tear film evident at all. That contact lens is sucked down because the patient has such horrible dry eye. And this is a patient that, obviously is in a bit of trouble if they want to continue to wear contact lenses. Now, you've probably seen this before. Typically we call it frothing. Some people call it fish eggs. And essentially what this is soaps. This is from saponification. Staph overpopulation occurs in association with Meibomian gland dysfunction. The saturated oils associated with MGD are a prime food source for staph. So staph tend to over-occupy the lid surfaces. They tend to be very territorial, so they release exotoxins. We sometimes see infiltrates because of those exotoxins. And they also secrete lipases. Lipases are enzymes that break down lipids. When those lipases mix with salt in the tears and the alkaline nature of the tear itself, you end up with soap making. And if you think for a second, and we'll talk more about this, what happens when you take soap and oil? It breaks down oil. So this is one of the things that actually makes meibomian gland dysfunction even worse. So if you have someone with mild meibomian gland dysfunction, they end up in much more serious difficulty when they have a lot of staph. So treating the lids becomes important, as we'll again discuss in just a minute. So meibomian gland dysfunction starts out as non-existent. There is no meibomian gland dysfunction. Every time the patient blinks, a nice copious amount of oil comes out and coats the tear film, and there's a reservoir of lipid and phospholipid, and it actually creates this coherent barrier which prevents evaporation. It increases lubricity and has a whole host of other functions. And the patient has no symptoms and does absolutely fine. It progresses to non-obvious meibomian gland dysfunction, which is something that we missed for years. This is something that Korb, the concept, I should say, that Korb introduced just a couple of years ago, that patients early on have what appears to be normal-looking lids, but they don't produce any lipid. And the only way to determine that is, yes, by diagnostic expression. It progressed to a more classic, obvious meibomian gland dysfunction to the point where it can get really horrific. And eventually, the glands become completely obstructed. So this is a process that occurs over time and worsens over time, leading to loss of function of the glands and leading to, in some cases, very, very severe problems. So non-obvious MGD is very, very important. It occurs in a significant number of patients. You really need to look for it because in patients, whether they have dry eye symptoms or not, this is an issue that will progress to become a more significant issue as time comes on. When you don't get secretion on normal expression, you really have to use more force. And as you can see in this picture on the right, you can see this toothpaste-like consistency meibome coming out. And obviously, that's really completely non-functional for its intended purpose. So let's talk a little bit about Meibography. To me, Meibography is perhaps the most valuable tool I have in assessing the dry eye patient, and certainly by far and away the most valuable tool I have in having a discussion with a patient who has dry eye. So this is, as I mentioned before, part of the Oculus Keratograph dry eye suite, which is a term that I use. And as you can see here, these are the meibomian glands. I tell patients it's like an X-ray. It's not an X-ray, but it's like an X-ray. Because they get that. They understand you're seeing something that they normally wouldn't see. And it allows me to visualize their meibomian glands, which are like clusters of grapes along a central duct. They put the upper and lower lid, and every time they blink, these glands are squeezed, and a little bit of oil comes out that supplies the tear film, and everything is happy. And these are reasonably normal glands. This is a patient who I would, say is reasonably normal. There's some glands missing in the bottom, or parts of glands missing in the bottom, but certainly this is reasonably normal compared to this. And here we have a patient that is symptomatic. You can see significant atrophy of the glands in the upper lid, glands in the lower lid. If you look towards the rightmost portion of the left image, you can see those glands are very hard to visualize. They are obstructed, and the architecture has been largely lost. And this is not in an elderly patient, by the way. This is in a younger patient. Here again, you can see the glands are thin, thready. There's curvature to the glands, which means the glands are actually stressed because of blockage. And you can see in the lower lid that half the glands are pretty much missing, and over towards the left-hand side, they're just little nubbins. This patient here is a patient that is almost non-functional. This is a 23-year-old woman who had to drop out of school. She can't work. She has horrible meibomian gland dysfunction, and we are treating her on a regular basis. And we'll talk about how to deal with patients who have virtually no meibomian gland function. We do, obviously whatever we can to restore meibomian gland function, and the jury's still out as to whether or not meibomian glands can actually be restored. I think they can be, but Donald Korb, for example, does not agree with me and thinks that once they're lost forever. But I do think that we may not be able to visualize glands; they're still partially there, and we'll talk about clearing them, and we'll talk about strategies for dealing with this. But again, this is a young patient. One of the things that I will sometimes use to assess, so I don't use it routinely clinically, is the Meibomian gland evaluator, Donald Korb's again invention, MGE. And essentially what it does is it applies a consistent force to the lid, mimicking the force applied by the blade. And what's good about it is it's very good for quantifying the amount of damage to Meibomian gland function, and this is really a measure of function. Another thing that we use a lot of these days, because we can actually write an RX for it and send it to the lab, before actually we had to draw blood, which was more of a pain and somewhat disruptive to the office, but now we use LabCorp to do show testing. This is by NIKBUT, and essentially what it does is it measures a number of novel genetic markers for Sjogren's syndrome beyond what we were able to do just literally 6-8 months ago. So it's very, very diagnostic for Sjogren's, and patients want to know it, and there are issues associated with it because the diagnosis is associated with significant morbidity, lymphoma, for example, and other issues, and it's important for I think it's important for patients to be aware of it, but you need to caution them that this will go in their health records, and some patients will prefer that you don't do it, but it is a very, very valuable tool for identifying patients with Sjogren's syndrome. So let's get into management, and we'll talk about my approach to managing those patients. Communication is critically important. If you're thinking that you're going to spend 15 minutes with a patient, you're not. And you're not going to be effective if you try to do that. Patient appointments are an hour. I don't spend an hour with them. They have about half an hour worth of workup, about 20 minutes or so, and I spend usually a half an hour of just direct interaction with the patient. And it's for the patient, it's different. For the patient, it's something that really is, I think, transformational because they're really being heard, and I have an opportunity to explain what's going on. And the way it works is relatively simple. I already talked a little bit about what we do. We go through a standard routine of testing. All of the patients are evaluated using the Keratograph dry eye suite. So they undergo Meibography, they undergo non-invasive break-up time testing, tear meniscus height. We have a Lipid view, which I'll talk about in a minute. They all undergo that, and then they're brought into the room, and basically I sit and explain how the tears work and go over the test results, and then do additional testing with the slit lamp and talk about that. It's important to recognize that the traditional way of thinking about dry eye, that it's mostly a aqueous deficient problem, is really not only passé, it's frankly incorrect. The vast majority of patients, even the ones who are aqueous deficient, have a significant component of Meibomian gland dysfunction. And often addressing Meibomian gland dysfunction is the most direct handle to actually addressing their problem. Now, I'm not saying all the other stuff doesn't work, although frankly it doesn't work as well as this strategy, at least in my hands. But it's important to recognize that the vast majority of patients that you're seeing that are symptomatic for dry eye can best be addressed by dealing with Meibomian gland dysfunction, addressing Meibomian gland dysfunction, and discussing it with them. Many patients self-treat. I don't have to tell you that they go into a pharmacy or to a drugstore, and there's literally a plethora of fancy colored bottles. There's literally a Visine for everything. In fact, earlier today I wanted to get Visine TR, but they were out of it. That's Visine tax relief. But well, a Visine for almost everything. And we need to understand how these drops work, and a lot of them really are nothing more than balanced salt solution, with a couple of chemicals thrown in. Some of them really are water and, or I should say, saline and methyl cellulose, which is to me really old school. Some of them actually are rather functional. I'm not going to go through an entire discussion. I'll just tell you exactly what I use. I very infrequently use blink tears. I do think there's a place for hyaluronic acid. Fresh coat can be very, very helpful for patients who have moderate to severe dry eye. I hold it as a last resort simply because A, it's expensive, and B, it's not distributed through a normal chain. It has to be done as behind the counter. We actually carry it in the office, and we started doing that. We never did that before, but now we're focused, or I should say I'm focused to the extent, or actually really the whole office is focused to the extent it is on dry eye. We do carry things that we never would have carried before. Refresh Advanced, Sustain Ultra, which to me is really the primary drop that we use, as I guess a palliative approach for most dry eye patients initially, and Sustain Balance. And those two are really what I use the most. And like every drop, they're far from perfect, but they can be helpful for some patients. If you're relying on drops, I think you're probably making a mistake. You really need to look at this as not just a drop issue. You really need to look at it more as an opportunity to intercede in what's going on and getting it back on track and fixing it. For the patients that have exposure, I really approach it in one of two ways. I really hate ointments, traditional ointments, but sometimes you have no choice. Some of the more viscous gels work reasonably well, which is okay. A company called iEcho, which is located in California, makes a silicone shield. Originally, that was designed for use with CPAP machines, because as you know, they blow air over the eye. If the eye has any exposure at all, these patients really just dry out, horrible, miserable dry eye. And this is nice because it actually creates a tight seal. In fact, it even maintains moisture because the little bit of sweat that occurs under it actually maintains a fairly high humidity moisture chamber under the shield. So I use that for some patients. Some patients don't like it. They don't like that sweaty feeling. Other patients, they can get away with that actually using an ointment. And again, very important to evaluate the patient for exposure. Very, very, very important. So let's talk about what I believe is the primary cause of dry eye, which is Meibomian lens dysfunction. The literature supports it. There are a number of papers. This is the classic paper by Lem and his associates that shows that 86% of patients have at least some component of evaporative dry eye. I actually think it's higher. And as I said before, whether it's higher or not higher, it is a way of assessing, or I shouldn't say assessing, accessing an appropriate therapy for these patients. Because, for example, if you have a patient with Sjogren's, if you can maintain what little tears they have, you're a heck of a lot better than trying to throw in drops, which really don't emulate a normal tear film. There's been a lot of focus on Meibomian lens dysfunction. I don't need to tell you that. You can get the executive summary from the International Workshop on MGD and read it. It's not that long and it's not that difficult to read, and I think that's an important element of the education. Education is very, very important. You really need to immerse yourself in this. Traditional therapy for Meibomian lens dysfunction, I learned about Meibomian lens dysfunction in the 1990s. I was actually educated by Eric Donenfeld and his associate Hank Perry. And Hank was big on Meibomian lens dysfunction. Eric was out of this fellowship, and I was struggling to understand why so many of my patients were having issues. And they were, acutely aware of Meibomian lens dysfunction, and I absorbed it. And warm compresses were the mainstay of therapy for the majority of these patients, who invariably fell off the wagon. And I now look back and I realize the reason why they fell off the wagon is because, number one, I really did stress expression, which is essential, and number two, the warm compress cooled off within less than a minute and really did nothing. So they all fell off the wagon because warm compresses just don't work. And I know some of you are saying potatoes and whatever, and frankly, they don't really work either. Reusable moist heat, and there are a number of companies that make things. Thermalized, instant thermalized beads are part of the iEcho system. I think their product is called Tranquil. In fact, it is called Tranquilize. I can see it. And there's another company called Bruder who makes another type of mask. Not quite moist heat, although they do say moist heat. I like the Tranquilize because it is moist heat, and I think it does actually raise the temperature in the lids at least a little bit. Not really as much as I'd like, but at least a little bit. And a little bit of massage. I don't want patients massaging vigorously because that can actually impact collagen fibrils in the cornea. There's been literature that suggests that, and that could be problematic. In fact, there's been at least one lawsuit that I'm aware of. So I just have the patients gently massage their eyelids afterwards. And I use this as a precursor to manual expression, which I'll explain in a second. One of the things that's really been actually amazing for me is this product called Eyelid Cleanser. And the Eyelid Cleanser, originally was sort of a ho-hum product, I thought. And it was actually my wife who brought it to my attention. I had a number of samples in the office, and she started using it and came home one day and said, "What the heck is in this stuff?" Patients are going nuts, and patients are coming back and asking for more of it. We actually now stock it, and I use it literally on every single dry eye patient I have. And the reason why I do is essentially what I expressed before. I can treat Meibomian gland dysfunction. I can even get lipid production, but the problem is if the staph is still present on the lids, it actually creates significant lipase production, which breaks down the lipids. If it's not lipase, it's cell production. Both of those things undermine the whole process of therapy by breaking down the lipids. This neutralizes the bacteria. It kills the bacteria very, very effectively. In fact, it's a very, very broad spectrum disinfectant. It completely neutralizes toxins, and it inactivates enzymes, including lipase. In fact, it was just a study that was completed that validated that, verified that. And what's really neat about it is it really makes a difference symptomatically for patients. Patients absolutely love this because it really helps reduce their symptoms. So it's a very important element in that. Conventional lid scrubs make, to me, absolutely no sense whatsoever because you don't want to add soap to a system that already is producing plenty of soap. You're just stripping oils off the skin, drying out the skin, and making the patients even less comfortable. So all those little pads that people were using, I think, are probably a really bad idea. So when you see a patient like this, a part of the problem is lipase production and saponification, which is damaging the lipid layer. Meibomian gland expression is critical. When patients have inspissated glands, when the glands are not producing clear, copious meibom, the glands need to be expressed because it's the only way to reset them and it's the only way to get them to function normally. And there are two ways of doing it. I basically tell patients it's bifurcated into two strategies. One of them is to do it manually, as you see here, and this is with a Mistrota-like paddle. I use a Mistrota paddle, or sometimes I use an Arita Forceps, which allows me to express the glands with a little bit more precision. Neither of these are very pleasant. I tell patients that the success rate is probably about 25%, give or take a little bit. It has to be repeated every 3 months. Sometimes the results are absolutely astounding. Patients do respond to it very, very well. I call this conservative treatment because it is less expensive and it is less technical, if you will. It is not a definitive strategy for managing Meibomian gland dysfunction because you just can't express the glands completely. There is no way to do that effectively. One of the things that is to me, a necessary concomitant of this, or a necessary precursor of Meibomian gland expression, is lid debridement. And here you can see using a golf club spud, which removes the excess skin, which is covering the Meibomian glands, the dead cells, and all of the keratinized tissue. Essentially, the line of marks, you would stain this patient with lissamine green, and you'd see this thickened line of marks, and that can be removed very easily. You can just remove the clearly visualized areas. I find this to be okay. It's not exactly the most effective or pleasant thing to do. Lately, I've actually switched over to the BlephX, which is really neat. I like this instrument. It's very beautifully engineered. It looks like a Porsche, very much like the Keratograph. Those are my two Porsche-like instruments within the practice. And what this does is it debrides the lids by using surgical foam. And patients generally don't particularly love it when you're doing it, but the results are very, very positive. Patients really see a significant improvement from it. I don't know if this is going to play or not. I think it's probably not. Well, it's okay. So essentially, basically that's run over the lids. It goes in two directions, and it just takes literally about 5-10 minutes at most. It's also very, very effective for blepharitis too. So I find that to be very helpful. Now, this is interesting, and I think you're going to find it kind of a novel approach to dealing with this. You need to address Meibomian gland dysfunction and the net result of it, dry eye, by changing the production of meibom. And the two approaches that I use are very simple. I offer the patient either a nutritional, specifically hydro eye, which I found to be the most effective of the bunch. If patients are using omega-3s, conventional omega-3 fatty acids, I have no issue with that. I think that's fine, and they can stick with it. But I find that hydro eye seems to be more effective, at least in my experience. And there's good scientific literature by credible people that supports that. And I tell them that that's the nutritional approach. And if finances are an issue, the other approach that works reasonably well is using oral doxycycline, and not 100 milligrams. I use 50 milligrams typically, but I offer that choice to them, and I explain that here are the pluses and here are the minuses, which I'm not going to bore you with. And I don't use both at the same time. I don't really think there's a need to, although again, I have no issue with them using omega-3s for general health reasons. Hydro Eye has GLA, gamma-linoleic acid, which has an anti-inflammatory capability beyond that of normal omega-3s. And doxycycline likewise, inhibits collagenolytic activity, inhibits PMN, chemotaxis, and has a whole host of other things. But it also does produce photosensitivity, which is an issue in Arizona. And there was, at one point, significant concern about increased risk of breast cancer. So, that's something that patients need to be aware of. I don't use this as much as I used to, but I typically, when I use a topical, I prefer azocyte over the combination products, simply because steroids are a short-term strategy. This can be used for longer-term strategy. In some ways, this is very much like doxycycline, but applied topically. Now, one of the things that's very important is the reason why patients have issues with meibomian gland dysfunction is because the weak link in this entire process is the blink. The blink is the weak link. What do I mean by that? Pre-industrial revolution, we were farmers and we looked out on the fields and we blinked to clear our eyes, and meibomian glands produced lipids that flowed onto the tears, and everything was fine. And Gutenberg invented the printing press. Next thing you know, whale oil lights kept people up reading late at night. And today, we literally live in a world that's driven by computers and smartphones and iPads and things like that. And our blink rate, as you well know, has diminished tremendously. And I think that's one of the reasons why we're seeing a veritable epidemic of dry eye in young people, because they literally have no blink. And we actually measure the blink with a LipiView. And I can tell you that these patients are blink deficient. So blink training is really an important element in therapy for these patients. You can get a free app, or the patient can get a free app. The core blinking exercise can be downloaded from iTunes. Unfortunately, there is no Android version, or you can actually download an instruction sheet. And part of any therapy that I use involves blink training for these patients, and they get with it. They do. At first, it seemed really hokey and weird to me, but it works. And the patients who fail are the ones who do not do this. They're the ones who come back and I'm able to get them back on track doing blinks. Blink training are the ones who actually become successful. Tear science technology I consider to be definitive. The LipiView off to the left, the LipiFlow in the middle. And that's an example of the activator or the disposable. Essentially a scleral lens surrounded by a well-controlled heating unit and silicone bladders, which actually apply a carefully programmed pressure to the lids to express meibom from the glands deeply and very effectively. This is FDA cleared, and I will tell you that it works not for every patient, but it works in the vast majority of patients extremely well. This is when we can, this is our go-to product. So I typically offer this as an alternative, and surprisingly, a significant number of patients, will go for it despite, the cost. Additional therapy, and when I say additional therapy, this is, for me, almost second-line therapy. I don't use it quite as much as I do the other things. Restasis, Restasis works for a percentage of patients. In my hands, not a very large percentage, but it does work well for some patients. What is important about Restasis is it is the only RX product, and it also, and Wes Allegan for doing this, has brought dry eye into the conversation of most Americans today. So pretty much everyone recognizes dry eye, and you will recognize the good doctor here who is who has shared her perspective, Dr. Temler, who's been the face of dry eye for a while, because she's a patient too. The combinations that I mentioned, I don't really use very, very often. I used to use them a lot with meibomian gland dysfunction. If there's a lot of inflammation, sometimes I'll have the patient apply this to their lids using their pinky, shake it, put a drop on the pinky, rub it into the eyelid margins, air dry, and then go to sleep. The problem is you can't do it in the morning. Most patients don't want to be bothered with it. I don't want patients, using it for more than 2 weeks. I don't see that as a a viable strategy. Sometimes I'll have them do it infrequently after that, but at this point we have so many effective treatments that work without these steroids that I rarely use them. And frankly, unless a patient is really in bad shape from an inflammatory point of view, I do avoid steroids. Although I just prescribed Pred Forte yesterday, so I occasionally do violate my own rules. And I typically use steroids in a pulse fashion, so I'll use it in BID or QID for up to a month and then just discontinue it. And sometimes that really does make a difference when the inflammation plays a significant role. But this is not for regular use. This is not a cure-all for dry eye. The complication profile is way too harsh, if you even consider that. And if it does work for patients, realize that patients tend to use what they like, and by hook or crook they find ways of getting it, which can be problematic. So there are certainly other strategies, that some of you use that I've certainly used in the past. I don't use punctal occlusion very much. For every plug I insert, I probably remove 5, 6, maybe more. And the reason why is I don't really want to trap tears that are filled with inflammatory mediators. I basically want normal balance to occur. So I'm not as big a fan of punctal occlusion as I used to be. There's certainly a place for it, but not the same place that existed in my mind in the past. I'm not going to get into some of the others, androgens, and I'm not going to get into autologous serum, although it certainly does have a role. I do want to talk about 2 things, though: bandage lenses and amniotic membrane, because those things are, I think, very, very important. The first, bandage contact lenses. Now, when I say bandage contact lens in a patient with dry eye, most of you are probably shuddering and saying, "Oh no, that's dangerous. The risk of infection is too high." And you're right. There is an increased risk of infection when using a bandage lens in a patient that has ocular surface disease. But there's also significant potential benefit for these patients. And in the end, it's risk to benefit. As long as you're doing it for the right reasons and you can justify what you're doing clinically, there's absolutely no reason why bandage lenses cannot be used in these patients. And in fact, we have had phenomenally good results with patients that have unstable corneas that are in typically bad shape using bandage lenses. And the patients are informed of the risks. The patients sign an informed consent. And we use it very, very judiciously. I'm not saying this is for every patient, but realize that it's within your bag of tricks. It's within your armamentarium, and it can make a significant difference for patients. The Procera is one of a number of amniotic membrane products. This is the only one that is cryopreserved, and we've had phenomenal success with it. It literally is probably one of the greatest breakthroughs in the history of eye care today, because we can take patients with ulcers that would have scarred, leaving them with 20/40, 20/60 acuity, and end up with 20/25, maybe even 20/20. We use it for patients that have, pretty much, think of any surface disease that produces significant corneal findings that would benefit from more rapid healing, and that is an indication for an amniotic membrane lens. Other lenses, these are freeze-dried. This is Ambiodisc by IOP Ophthalmics, and there's another one made by Seed Biotech, the Arrow. And there's argument as to which one works better. The cryopreserved, version, which has a scleral ring, versus this, which is placed on, the area, the defect itself, and then typically covered with contact lens or placed within the contact lens, depending on, the application. But we've had good success with all of them in different ways. And if you're not using this technology, I strongly suggest, I urge you, if you can, legally within your state, consider it. It does make a significant difference, and can be, for some patients, literally life-changing, The last thing I want to talk about is scleral contact lenses. Not long ago, I sent an email to a good friend of mine, a contemporary, and I said to her, you limiting your practice to scleral lenses, are you crazy? Why are you doing that? We both come from a place where, I can't think of anything that I couldn't fit with a conventional corneal lens. And she wrote back, well, if you start using them, I think you'll see, the difference, and why I think sclerals are, went through major, advance in eye care, and I said, okay, whatever. And anyway, we started using them, and this is right now not the last stop, but at the very end of the line of things that we do for patients who have dry eye. So when we have a patient that literally has failed everything, and the patient is in agony and isn't doing well, and the bandage lens isn't appropriate, scleral lenses will more often than not, in fact almost always, save the day as long as the patient can be trained. And we've had unbelievable results with scleral lenses. Now, to fit them properly, it would be nice if you had an OCT. That's very helpful, but not absolutely essential. It creates essentially a sealed off moisture chamber, which is protective and functional for these patients, and they do amazingly well. So this is something that you really need to keep in mind. And if you're not facile with any scleral lenses, and this is an area that you want to get involved in, I strongly recommend that you become skilled with it. So as we come to the end, I just want to share with you that this is one of the most gratifying areas of eye care. I've had an amazing career. I've done some amazing things in my career, and I've worked with some unbelievably gifted people. And my focus has, for many years, been ocular surface or anterior segment, and more and more leading to the ocular surface. It seems to be such a small area, but yet it's an area where you can do so much amazing good for so many people in need. The population who have issues is increasing dramatically. The technology is advancing incredibly. Our knowledge is literally exploding, and this is an area where I really think it's going to define the future course of our profession. We worry about so many things. As long as we're taking care of people and making a difference in their lives, we'll be relevant, and the profession will be viable. For those of you who have not used a amniotic membrane lens, speak to a rep. Look it up on the internet. Get some experience with it. It can be life-changing for your patients. If you're thinking of getting a topographer or replacing a topographer, look at the Oculus. And I'm not just saying it because Oculus was kind enough to sponsor this. It does things that nothing else does, and it literally changes the way you go about managing these patients and communicating with these patients, which is a critical point. So I hope this has been helpful. I hope you've gotten something that you can apply tomorrow with it. And I apologize for the miscues that we had in the beginning, but unfortunately, I guess that's the nature of life. So, Craig, I'm going to turn it back to you, and thank everyone for spending some time with me this evening, and thanks again for sponsoring this.
Dr. Epstein, thank you very much for this knowledgeable webinar. It was exceptional. There are a few questions I'd like to ask, though. Number one, is the eyelid cleanser toxic to the epithelium?
No, actually, that's a great question. It is hypochlorous acid, which is produced by neutrophils, and so it's basically used by the body's own defense system, and its ability to damage bacterial cells and fungi and viruses and pathogens is several orders of magnitude greater than its ability to damage human tissue cells. So basically, you literally can take eyelid cleanser and pour it into your eye and have no issues. You can spray it into your mouth, and other than a tiny chlorine taste, it actually has no effect at all. That's really the neat thing about it. It basically leverages the body's own defense system, against the pathogens.
Thank you. Another question here. Does the Keratograph test for partial blinking? Are you able to do that with the Keratograph?
Does it? I'm sorry, ask again.
Does it test for partial blinking?
Actually, that's interesting. Someone's a mind reader. It does at those points, but I actually have had that discussion, and I do think that is one of the things that will be added in software. I think it's certainly capable of doing it because it uses the blink as a trigger for testing, so it should be able to measure for partial blinking at some point.
With the Keratograph, when you're looking at the lipid layer, you're actually able to see the full or partial blinking. So not only it's not testing for it now, but visually you can see that if you are doing a lipid layer scan, you're able to see if the upper and lower lid do touch each other. Another question here is, what does Dr. Epstein think about OcuSauce Tears Again Advanced Eyelid Spray Liposome Spray?
Not much. I mean, you're forgive me for being blunt, but some patients seem to like it, but I'm not a big fan of spraying stuff in people's eyes, again, the lipids that are, you have to look very, very closely at all the products that are on the market. The products that I find to be the most successful are at least tip their hat, nod in agreement with what nature produces. And when it comes to lipids, what nature produces are not simple lipids. They're really complex lipids, and phospholipids that work synergistically together. So if you look at a product like Sustained Balance, it is a mixture of conventional lipid, or I should say conventional lipid, non-polar lipid, and phospholipid. If you look at Fresh Coat, it actually, again, they don't reveal what exactly is in it, but they do say that they do have phospholipids. So, I tend to look at lipid products, lipid-based products, as supportive when they more naturally mimic the constituents of a normal lipid layer, or normal meibom, I should say.
Thank you very much. Does the Oculus Keratograph also give you K values and the full corneal topography?
Yeah, it does. I used I actually, what did I use? For many, many years, I used I'm blocking on the company's topographers. One of the first topographers around. When I first saw a topographer, said, "Oh, who needs that? I just need a contact lens of a known diameter. I'll look at the fluorescein pattern. I can figure anything out." About 6 months later, we were buying. Oh, it's Tomei. We had a Tomei, and I love that Tomei. I used it for years and years, and I find the Keratograph to be, actually what I would have dreamt of the Tomei evolving into when it grew up. So it pretty much does everything that. In fact, not only does it do everything that a normal topographer does, but it does things that normal topographers don't do, like three-dimensional images that are in real time that you can show to patients, and really neat in terms of communication.
Thank you very much, Dr. Epstein, for the webinar this evening on behalf of Oculus, as well as on behalf of all the participants this evening. Thank you very much, and have yourselves a good evening.